Thank you very much, Mr. Chairman, for the kind introduction. It has been a long journey with a lot of missed flights, delays, lost luggages, but the destination is great with very nice people, very close friends, and we are really happy to be here. So thank you very much. My topic is regarding peritoneal endometriosis and endometriomas. So before starting, I would like some extra time, please. Okay. Anyway, so key points. I think we should focus on specific questions to try to find out what is happening and what can we do for this problem. Does laparoscopy improve fertility in women with early-stage endometriosis? What is the best surgical treatment for peritoneal endometriosis? Which are the available surgical treatments for endometrioma? Safety and ovarian reserve. Again, of course, it's a huge thing. And should we perform laparoscopy prior to IRT in order to increase our fertility rates when we have peritoneal endometriosis or endometriomas? According to our guidelines, we can perform laparoscopy and we can offer it as a treatment option for early-stage endometriosis because it has been shown that it improves the rate of ongoing pregnancy rates for these women. That's one of the meta-analyses in 2014. Which has demonstrated by using retrospective and randomized trials that if we compare the outcome of laparoscopic surgery versus controls, the results are in favor for clinical pregnancy rates for the group of laparoscopic treatment. That's a recent network meta-analysis with 14 interventions. The lines correspond to the interventions, the thickness, the number of the papers, and in the end, the outcome is that the surgical treatment versus control is improving significantly the chances for these women to achieve spontaneous clinical pregnancy. And the most recent meta-analysis by Bafford, which has been an update of the old one from Jacobson in 2010, Duff from 2014, and demonstrates again the superiority of laparoscopic treatment versus diagnostic one for the achievement of a viable intrauterine pregnancy. But what is the best surgical treatment we could use for peritoneal endometriosis in order to achieve pregnancy? Actually, throughout the guidelines, we cannot find a specific recommendation. Both excisional techniques and ablative techniques have been proposed as equal. Of course, dissection and excision requires higher surgical skills. Recent meta-analysis by Barks tried to compare excision versus ablation with CO2 or thermal destruction with diathermy. They couldn't find any significant difference for a follow-up of 6 and 12 months for the outcome of pain, dyspareunia, and dysmenorrhea. As for Plotho, he proposes that we should use either excision or thermal ablation with laser instead of monopolar diathermy if we want to achieve higher number of pregnancies. That was based in one study from Chan in 1977. And the Cochrane meta-analysis for the outcome of pain, they couldn't identify any superiority between the two techniques, the laparoscopic excision or the laparoscopic thermal ablation of peritoneal endometriosis. The group from Gortz and his colleagues from Belgium, they've been using hydrolaparoscopy for a lot of years. They published a large retrospective study of more than 2,500 women. Between them, there were about 300 women with early-stage endometriosis, and they have demonstrated that if we destroy these spots of peritoneal endometriosis with miniature bipolar probes, we will achieve a cumulative pregnancy rate within 8 months after the treatment of more than 50%. And the group from Italy recently published this paper, a retrospective study again, for the use of CO2 laser, a significant improvement to the symptoms of pain and significant improvement for the quality of life. 100 of these women opted for a pregnancy. For this group, they found out that within 24 months of follow-up, 80% of them achieved spontaneous pregnancy. Should we perform laparoscopic treatment before IVF in order to improve our results? That was a huge difference from our recent guidelines in comparison with the previous one. We shouldn't be doing that. And there is a lot of data confirming that. We have had this meta-analysis from 2013, comparison early-stage endometriosis versus control, outcomes of IVF and ICSI, similar clinical pregnancy rates, and similar live birth rates for both groups. Indirect data from this meta-analysis also for all stages of endometriosis versus control, and fertility outcomes for live birth rate, clinical pregnancy rate, oocytes retrieved, no difference at all. And comparison of early-stage endometriosis versus advanced endometriosis and IVF outcomes, again, the same results. And of course, the known meta-analysis by Hamdan, which was actually with higher quality of papers and much larger patients participated in this meta-analysis. Again, the comparison between the endometriosis and versus no endometriosis and outcome of IVF and ICSI, similar clinical and pregnancy rates. And in this same meta-analysis, we have data also from a subgroup analysis from women who have been treated laparoscopically for endometriosis early stage versus controls. And again, this subgroup analysis didn't show any difference at all on the outcome of live birth rate and clinical pregnancy rates. So I think, in conclusion, for peritoneal endometriosis, it's legitimate to say that indeed surgical excision or ablation of this peritoneal disease will enhance the fecundity of these women. But on the other hand, the outcome of IVF is not influenced by the presence of early-stage endometriosis. And if we are going to perform IVF, we shouldn't operate all patients in order to achieve higher rates. That was the first part, and we move to the second one. I'm sure you all know Plato, the Greek philosopher, who has said that repetition is the mother of knowledge. Επανάληψη μήτρη πάσης μαθήσεως. That means that I'm going to say some things that you have already heard, but I think we need to discuss them again and to see which are the considerations that we need to take into account. The outcome of the surgery is surgeon-dependent. We have the delay in commencing the RT if we do the operation. We have the cost of the surgery. We have the risk of surgical complications. And of course, as we all know now, we have the potential adverse effect on ovarian reserve. And our guidelines say that we may consider operative laparoscopy for the treatment of endometrioma-associated infertility, as it may increase the chance for natural pregnancy, although, as we have heard earlier, there are no comparative studies, and this is difficult to have it. Anyway, that was the main outcome, and as you have heard earlier, there is this meta-analysis that shows that at least for a follow-up of 2 years, surgical treatment of endometriomas and regarding the achievement of natural pregnancy is not inferior to other techniques that might be used. But, of course, here starts the question, we shouldn't perform surgery for ovarian endometriomas prior to RRT to improve our live birth rates. That means that we shouldn't operate endometriomas if we are going to do IVF. One of the first and largest meta-analyses with more than 30 papers, comparison of intact endometrioma group versus no endometrioma and outcomes of live birth rates and clinical pregnancy rates have been similar. But for the group for endometrioma, authors concluded that we have a lower number of oocytes and higher cancellation rates. And then the same meta-analysis, there is the subgroup analysis for women who have been treated laparoscopically for endometriomas versus intact endometrioma. And here the results obviously show that we have similar live birth rates, similar clinical pregnancy rates, and similar oocytes numbers between the two groups. What's the effect of surgical management of endometrioma on IVF ICSI outcomes when we compared with no treatment? The meta-analysis from Nico Amiri, live birth rate per cycle, clinical pregnancy rate per cycle, pregnancy per cycle, no difference at all between women who have been treated laparoscopically for endometrioma and women with intact endometrioma. No difference to the oocytes, to the embryos per cycle, and no difference to the dose of FSH for stimulation. And all this confirmed again from another more recent meta-analysis, the same thing, endometrioma versus control, IVF ICSI, similar live birth rates, clinical pregnancy rates, and implantation rates. So it's legitimate to say that surgical removal of endometriomas before in vitro fertilization or ICSI does not improve the chance of live birth for these women. We do know, we do understand that surgery for endometriosis is a very delicate thing. We need to operate usually young women who want to preserve their fertility or improve their fertility, to treat them for the symptoms of pain and not to harm them. We know that we have specific surgical options which are proposed by both ESHRE and ESHRE, cystectomy, the stripping technique, ablation by using laser, bipolar, plasma or sclerotherapy, and the combined techniques, the three-step approach with drainage, GnRH, and then ablation, or the one-step technique combining both stripping and CO2 laser. Cystectomy has been used for a lot of years and actually has been demonstrated that it is the gold standard in order to achieve higher pregnancy rates and lower risk for recurrence of the endometrioma. Of course, it needs specific surgical skills not to damage the healthy ovarian tissue, but if it's performed properly, we have also a lower risk for recurrence of the endometrioma and, of course, the symptoms of pain. While the combined techniques, actually, most of the time, they combine both cystectomy and the use of ablative techniques, and they are proposed as less aggressive approaches, especially when we are dealing with larger endometriomas. Ovarian cystectomy versus laser vaporization, that was a very nice randomized trial, which concluded that as for the pregnancy rates between the two techniques, we have no difference at all. We have similar achievement for pregnancy. As for the recurrence, according to this randomized trial, the first 12 months, cystectomy is superior to laser. But if we see the outcome after 60 months, this difference becomes non-significant. And then a randomized trial comparing cystectomy versus laparoscopic treatment with diathermy or with the use of laser, demonstrated that cystectomy is better from both techniques as for the recurrence of the symptoms, and it is better also for the endometrioma recurrence. But as for the pregnancy rates, according to this meta-analysis, the outcome is similar when we use cystectomy versus laser, and it's better for cystectomy if we decide to use ablation with bipolar diathermy. Safety comes first for our patient and for the ovarian reserve, so we need to look to this problem a bit more carefully. We do know, and we have heard that our interventions and cystectomy, as it has been used for so many years, is sometimes detrimental for the antral follicle counts and the AMH of these patients. And also, this impact becomes more severe if we operate bilateral endometriomas instead of unilateral pathology. And the worst comes when we have to reoperate these women. This reoperation will be even more harmful for their ovarian reserve by reducing AMH, antral follicles, and the volume of the healthy ovarian tissue. According to this randomized trial, size plays a role, and it is significant. The larger the endometrioma, the more significant is the reduction of the AMH, irrespective if we use cystectomy or laser. And they propose the size of 5 centimeters. Cystectomy, is it really so bad? Do we do something wrong when we perform cystectomy? It must be something which is causing all this detrimental effect, and authors believe that one of the things that we should be careful is the use of diathermy. According to this meta-analysis, if we perform a cystectomy for women and we don't use bipolar diathermy for the hemostasis, then the outcome will be much better for their AMH if we use other methods to perform hemostasis instead of bipolar. In this randomized trial, authors randomized cystectomies, women with bipolar versus women suturing of the ovary in order to perform hemostasis, and they found out that the outcome for the AMH was much significantly better for the suture technique. And this is another randomized trial which compared the use of bipolar diathermy and the use of hemostatic agents for the hemostasis, and they found out that bipolar energy, again, it was worse for the AMH of these patients. A recent network meta-analysis just published a few months ago, they compared various interventions, ultracision, bipolar, suturing, hemostatic sealants, and they said, authors, that bipolar and ultrasound are forbidden for the AMH of our patients. Hemostatic agents are better, but what is best, according to this meta-analysis, is just to place a stitch on the ovary in order to avoid bleeding. And just published from Japan a couple of months ago, another meta-analysis of a comparison of the ovarian reserve after cystectomy of ovarian endometrioma, and they compared bipolar coagulation versus suturing or versus hemostatic sealants. And the results for a follow-up up to 12 months after the interventions are against the use of bipolar diathermy as a hemostatic method after we perform cystectomy. So this is a very crucial thing about the technique we have been using all these years. What about novel technology we have been hearing? We've seen some very nice videos, and I'm happy that I was allowed to present them again from our colleagues. Do we need to remove so much tissue in order to treat the endometrioma? When we do know that actually the depth of the pathology that needs to be removed is only about 0.6 millimeters. Why not using something else, a thermal energy, which is not penetrating a lot the tissue, is not diffusing this thermal damage to the rest of the ovary, to try to visualize, exteriorize the pathology and destroy it by this way? Well, there was this very, very nice and, I would say, clever randomized trial. Authors and Ludovico Muggi, they randomized the ovaries, one size, bilateral endometriomas. One ovary was treated by cystectomy, and the other ovary of the same patient was treated with a combined excisional and ablative technique. And he has demonstrated that the ovarian volume was significantly reduced for the ovaries who have been treated with cystectomy for the same patients. And another randomized trial, again with endometriomas of more than 3 centimeters. The outcomes were antral follicles and AMH, and it has been shown that comparing one-step laser technique versus cystectomy, the AMH was significantly lower for cystectomy. As for the efficacy and the safety and the risk of recurrence of the pathology to our patients, this nice retrospective large study with a follow-up of almost 30 months demonstrated that the outcome, if we compare it with cystectomy versus CO2 laser, is similar endometrioma recurrence rates and similar pain recurrence rates. So we do understand that any intervention to the ovary might have a bad or detrimental effect to the fertility, future fertility of our patients. Both cystectomy and laser are reducing the number of the antral follicles and the AMH. Perhaps, though, the use of laser is a bit safer according to this recently published meta-analysis. We have heard about sclerotherapy, which is started to being used again from some centers. There are a lot of publications for sclerotherapy via ultrasound, via laparoscopy. I think the most well-described approach is the one by Professor Horace Roman. He's describing a 10 steps technique, how to prepare, puncture, aspirate, and then introduce the ethanol in a safe way so that we won't have any spillage to the abdominal cavity. And actually, his group has published a few small studies with, not a large number of patients, but he demonstrated that there is a recurrence rate of about 11 to 12% with this treatment, and pregnancies in the following months achieved more than 40%. And there is this meta-analysis which compared sclerotherapy versus other techniques, and in this graph we see the comparison between sclerotherapy and cystectomy. There's no significant difference on the outcome of clinical pregnancy rates, and no significant difference on the outcome of recurrence. And a more recently published meta-analysis again for sclerotherapy and cystectomy, 8 comparative studies. And in this meta-analysis, also authors demonstrated the non-inferiority of this technique versus cystectomy regarding the recurrence and the clinical pregnancy rates for these patients. I think since we are talking about treatment of endometriomas and fertility, we are somewhere there. That's a very nice article, review article published a few months ago. And actually, we can see that as for the pregnancy rates, all our techniques, apart from electrosurgery, bipolar diathermy, are good. So electrosurgery with bipolar should be abandoned. As for the recurrence rates, cystectomy and laser seem to be similar, which is good. As for plasma and sclerotherapy, there is a question mark, which I have put myself, because we don't have a lot of data, and I think we need more studies to use. But electrosurgery shows higher significantly recurrence rates. That means it should be abandoned. And as for the effect to AMH, all these new techniques, laser, plasma ablation, and electrosurgery, they seem to have a lower negative effect to the AMH. Electrosurgery should be abandoned. What about cystectomy? Is this really what we see? Is this the reality? Don't forget that we have been using cystectomy for years, and a lot of studies have been with techniques using extensively the bipolar diathermy. If we try to improve ourselves, if we try to use other methods like suturing the ovary, if we have extensive bleeding and we need to perform a hemostasis, could that positively affect our AMH after cystectomy and have a similar result? Personally, I believe so. But what I do really believe is that we need to have guidelines, we need to have rules. We need to select properly our patients and to decide who is going to operate it and who is not. And also, we are able now to predict the outcome of our operation. We have tools. We know that bilateral disease is going to give a poor post-operative ovarian reserve outcome, reoperation of the recurrence, large endometriomas, advanced stage of the disease, and perhaps AMH levels before operation. There are levels, specific levels, we are still looking for it, but they could give us a hint what's going to happen, and perhaps to cancel our patients in another way. Perhaps we should reconsider when we operate our patients. According to this recently published randomized trial, authors believe that it is better to operate our patients in the late luteal phase, because there is a loosening of this border between the capsule and the healthy ovarian tissue, and perhaps it is easier the peeling off of this capsule during this phase. This is what has been demonstrated in this randomized trial comparing operation with early and late luteal phase, and the outcome was the AMH decline. And of course, we've seen this slide earlier. Perhaps we could profit of our medications and the Enogest to give it a couple of months before and a couple of months after the operation. It might enhance and improve the results of AMH. But we should operate our patients properly, and we should give the chance to the nature, to the body of the woman, to the ovary, to recover. And there are mechanisms to do so, we do know that, unless we destroy everything. So this is why sometimes in the literature we see a decline of the AMH, and then suddenly after 6 months, 12 months, the AMH goes up, because our body, the body of the woman, is trying to compensate. And this exists, but we need to give it a chance to do so. And of course, recurrence is a huge issue. when we have a recurrence, I think we should think twice. And we should ask, does the woman want to become pregnant or no? If she doesn't and we have symptoms of pain, why not use all these medications we have in our hands? And if they are not successful, then we operate. But if the patient wants to become pregnant, we do a fertility workup. And then we decide, if she wants now to become pregnant, perhaps we should advise for IVF or ICSI. If she's feeling that she needs to become pregnant in the future, perhaps we should advise for freezing eggs. So in conclusion, it seems that the reduction of ovarian reserve after surgery for endometrioma is something inevitable, regardless of the technique. The decline of this ovarian reserve is multifactorial, surgical skills, size, history, etc. Surgical treatment prior to ART in order to improve fertility cannot be recommended in general, but only in very specific indications. Novel technologies of laser and sclerotherapy seem to be promising, but we need more data. And don't forget the prediction and egg freezing preoperatively for all these patients. And I'm sure that you have seen this to a lot of presentations, that management of endometriosis is not one size that fits all, and we need to follow an individualized approach for our patients. So thank you very much, and I'm ready for questions.